Good afternoon. My name is Dr. Day. I am Section Chief of Breast Imaging and Chief of Radiology at MedStar Good Samaritan and MedStar Union Memorial Hospitals in Baltimore, Maryland, and I'm here today to talk to you about screening mammography. I have no financial disclosures. Breast cancer is a significant health risk worldwide with more than 2 million cases occurring annually. Breast cancer will develop in 1 in 8 women in their lifetime, and breast cancer is the leading cause of cancer death for women in the United States. The public health policy which has had the most impact on breast cancer mortality has been screening mammography. The goal of screening mammography is the early detection of stage 1 node-negative breast cancer. So with the widespread utilization of mammography in the mid-1980s, there was a resultant decrease in mortality from this particular disease. However, in the African American population, while the incidence of breast cancer was slightly less than that of the Caucasian population, there was a stark difference in mortality, with recent American Cancer Society data confirming that non-Hispanic Black women have death rates 39% higher than non-Hispanic white women. And the question is, why? The causes of the mortality disparity are multifactorial and include tumor biology as well as social determinants of health. However, this particular talk is going to focus on screening mammography utilization, as that has been shown to have quite the impact on mortality. So there are multiple factors that affect screening mammography utilization, and they include public policy, healthcare insurance, primary care physician provider access and referral, as well as screening guidelines. So the public policy factor has been the most profound factor on screening mammography. So the USPSTF is the United States Preventive Services Task Force, and it's an independent volunteer panel in the fields of preventive medicine and primary care. And they develop recommendations for screening guidelines across multiple disciplines. So the USPSTF policy in 2002 was annual mammography beginning at the age of 40 and every 1 to 2 years thereafter. However, in 2009, there was a pivot and the mammography recommendations changed to every 2 years between the ages of 50 and 74. With respect to the patient population aged 40 to 49, the language in the recommendation states that the decision to start regular biennial screening mammography before the age of 50 years should be an individual one and take patient context into account, including the patient's values regarding specific benefits and harms. So how did this affect mammography utilization? The vertical axis demonstrates the number of mammograms per 1,000 women. And you can see that in 2005, there was an average of approximately 311 mammograms per 1,000 women, with an incremental increase of approximately 1% to a peak in 2009 of approximately 322 mammograms per 1,000 women. After the USPSTF guidelines, that number plummeted rather dramatically to a level of approximately 309 screening mammograms per 1,000 women. So the USPSTF 2015 recommendations doubled down on the USPSTF 2009 recommendations, again stating that biennial screening beginning at the ages between 50 and 74 is recommended, which is a B rating. Screening between the ages of 40 and 49 should be determined on a personal basis, which is given a C rating, and given a C rating, and the recommendation for screening mammography after the age of 74 is given an I rating. The I rating states that the current evidence is insufficient to assess the balance of benefits and harms regarding this particular service. So this is a brief slide which demonstrates the number of breast cancer deaths avoided, comparing the meta-analysis of the RCT data, which the USPSTF recommendations are based upon, and the CISNET modeling comparing annual and biannual screening schedules. And you can see that the number of breast cancer deaths avoided is most when you use an annual screening mammography schedule. And the second most impactful decrease in breast cancer deaths is used by the biannual screening mammography schedule. Additionally, this is a chart demonstrating the performance of screening mammography from the Breast Cancer Surveillance Consortium. And it demonstrates that the sensitivity for finding breast cancer with respect to screening mammography does increase as the patient ages. So you can see in the cohort of patients that is aged 70 and older, the sensitivity of mammography increases, the positive predictive mammography, as well as the positive predictive value of mammography. So breast cancer utilization or screening mammography utilization in this population of patients is useful and does find cancer. So the USPSTF recommendations leave two large populations of women at risk for decreased mammography referrals based on policy, as well as decreased insurance coverage. And this is because insurance carriers typically use the USPSTF guidelines for reimbursement. African Americans are twice as likely as non-Hispanic white Americans to be uninsured or underinsured, and as a result are less likely to undergo screening and are thereby finding cancers at later stage of diagnosis. So with respect to public policy, potential solutions would include extending the evidence base to include observational studies of high-risk populations. Approximately 25% of breast cancer in African American women is diagnosed before the age of 50 versus approximately 16% of those cancers in white women. This would result in lowering the threshold ages for screening, thereby finding more stage 1 cancers. And additionally, supporting research regarding access to screening mammography in terms of affecting public policy. With respect to healthcare coverage, potential solutions would include all insurers following the Medicare guidelines as covering baseline mammography between the ages of 35 and 39 and yearly thereafter the age of 40. The Affordable Care Act demonstrates cost sharing, thereby eliminating out-of-pocket costs only for screening studies given in A or a B. And the addition of navigation programs such as the breast cervical cancer program, which provides access to screening and diagnostic mammography, as well as ultrasound and image-guided procedures. Additionally, if patients are diagnosed with breast cancer, they guide the patient through the process. And in addition, they assist patients in applying for insurance. So another piece to the puzzle is primary care access. One of the best predictors to obtaining screening mammography and systematic review focused on minority populations demonstrates that working with providers to encourage participation in screening was more effective than working directly with patients. Underserved communities often access the healthcare system during emergencies, so no screening recommendations are there are no screening recommendations at this particular point of care. So this graph demonstrates on the vertical axis the percentage of patients presenting for screening mammography. The red line demonstrates the utilization of mammography with patients who have a high primary care physician engagement, and the blue line demonstrates those patients who have a low primary care physician engagement. And you can see that those patients who are more engaged with primary care physicians have a higher utilization of mammography overall. And another indication of primary care, another impact of primary care is the actual referral pattern. So once the patients get to their primary care physician, what exactly is the recommendation? So prior to the USPSTF recommendations of 2009, there was approximately a 53% referral by primary care for screening mammography. Post USPSTF 2009 guidelines, the decrease was approximately on the order of 20%. So before 2009, the American College of Radiology, the American Congress of Obstetricians and Gynecologists, the American Academy of Family Physicians, and the American College of Physicians all advocated beginning screening at the age of 40 with screening intervals of approximately 1 to 2 years. After 2009, the American Academy of Family Physicians and the American College of Physicians shifted their recommendations to mirror that of the USPSTF and recommended biennial screening for women aged 50 to 74 years. So this is a graphic illustration of the effect of the USPSTF recommendations on screening mammography recommendations in patients that are in their 40s. And you can see that the recommendations, the referrals for mammography for women in that particular age cohort did increase until the 2009, and thereafter there has been variability in recommendations and referrals. So in summary, the primary care referral patterns had decreased approximately 25% pre and post USPSTF. There is a significant decrease in referral rates amongst internal medicine and family medicine physicians, which are consistent with their society guidelines. And the biggest decline in referrals occurred in the patient population aged greater than 75 years. And this is just graphic data, just demonstrating what was summarized previously. So this is a table of US mammography referral rates over time by patient and visit characteristics. So it breaks it down into by age, ethnicity, region of the country, physician specialty, as well as payment source. This graph is a little bit, or this table is a little bit more telling in that they subgroup this by age cohort as well as subspecialty. And the biggest decrease in mammography referral pre and post USPSTF 2009 has been in the general or family practice and internal medicine practices, with resultant decreases of approximately 20 to 30% across all age populations, most notably in patients older than the age of 75, where the referral pattern decreased on the order of approximately 78%. The OBGYN referrals did decrease, but not to the level of the internal medicine or family practice specialties. So what are the solutions to this possible problem? Educating primary care physicians and providers regarding the science behind the ACR and SBI guidelines for average risk patients. Educating primary care physicians and providers regarding the science behind the ACR and SBI guidelines for mammography for high-risk patients. So what is the best screening strategy? So this is a table of multiple screening strategies that we've spoken about earlier in the talk. And essentially, the American College of Radiology recommends that all women, especially African-American women, and those of Ashkenazi Jewish descent, should be evaluated for breast cancer risk no later than the age of 30. And if the patient is of average risk, they shall begin screening mammography at the age of 40, no later than the age of 45. And they shall continue as long as the woman is in good health, chooses to be screened, and tends to seek and tolerate treatment, and or the life expectancy is equal to or greater than 10 years. These recommendations are in line with those of the Society of Breast Imaging, the National Comprehensive Cancer Network, the American Society of Breast Surgeons, as well as the Society of Surgical Oncology. Annual mammography, beginning at the age of 40 years, achieves the greatest mortality reduction for women at average risk. Risk assessment tools identify those patients who may benefit from more intensive screening programs. Until African American women are actively encouraged to undergo both risk assessment at the latest at the age of 30 and annual screening mammography, the disparities in mortalities will persist. Thank you.